Good morning, students. Today, my class is adrenergic agonists. But before going to this, you have already learned about the, adrenergic system in the first year, that how this phenylalanine is converted to the adrenaline, and what are the neurotransmitters, what are the adrenergic receptors, what are the kinds of the adrenergic receptors, and in which tissue the alpha 1, alpha 2, beta 1, beta 2 or beta 3 are there, and what is their receptor mechanism behind, and also the therapeutic clinical classification we have to deal with, like what are catecholamines, what are non-catecholamines. These are the things which you have to discuss, and what is the depending on the mode of action of the neurotransmitters, what are the directly acting sympathomimetic amines, what are the indirectly drug acting sympathomimetic amines, what are mixed action amines, and what are the catecholamines reuptake mechanism, which are very important so far as the other drugs are concerned, like we have a tricyclic antidepressant, like we have a SSRIs, like we have other classifications. And therapeutic use of the these adrenergic agonists, we have vasopressors, cardiac stimulants, CNS stimulants, bronchodilators, nasal decongestants, appetite suppressants, and uterine relaxants. And we have to describe the adrenaline, its importance, it is in maintaining in the blood pressure, in the hypovolemia, is it indicated or contraindicated, and what are its uses in the this in case of hypersensitivity type 1, and we have other uses, their pharmacokinetics, pharmacodynamics, and what is the MOV and COMET, how they are being metabolized, and what is their mechanism behind. And also we have to take the long indication of the adrenergic agonists in the cardiac muscle, in the cardiac arrest, in the hypotension, in the chronic orthostatic hypotension, in the hypertension, in the cardiogenic shock, in the cardiac decompensation, and AV block. And what is the hypersensitivity? We use it anaphylactic shock, and severe allergic reactions we use it. We are using it in the local vasoconstrictor, and in the CNS we use it for the narcolepsy. We use attention deficit hyperactivity disorder, obesity, respiratory and bronchial asthma, ocular and glaucoma, myasthenia gravis for fundoscopy, and genitourinary system uterine relaxants, and nocturnal aneurysms in children. We use ephedrine, and overactive bladder. So there are a lot of pharmacological activities in sympathomimetic are concerned. Then we have noradrenaline, adrenaline. What is the difference, and how we maintain its differences, and what are according to Ahlquist, what is the difference between adrenaline, noradrenaline, compare and contrast. Both are catecholamines, and then noradrenaline and noradrenaline and epinephrine. What is their compare and contrast? This is very important so far as the pharmacology is concerned. And vasopressors, nasal decongestants, and this is all about the nutshell. We have a tremendous scope to describe these things. Now, so far as the receptors are concerned, adrenoreceptors are alpha. We have alpha 1 and alpha 2. Then we have a beta 1, beta 2, and beta 3. And dopamine also is the adrenergic receptor. We have subsets of D1 to D5, D1, D2, D3, D4, and D5. Now, adrenergic or sympathomimetic drugs. These are the agents which can produce pharmacological properties similar to those produced by adrenaline or noradrenaline. They can also potentiate the activity of adrenaline or noradrenaline, or can stimulate adrenergic neurons, sympathetic neurons, to release adrenaline. Now, so far as this is concerned, you have to see adrenoreceptors at alpha 1, alpha 2, beta 1, and beta 2. These are the main classes. There are other subclasses, and we can see alpha 1 agonists. They are the vasoconstrictors. They increase the peripheral resistance, and they increase the, I would say, blood pressure, and they increase the, they are used in the mydriasis, and also increase closure of the internal sphincter of the bladder. The alpha 2 is a, it can be used in the in so many. It is the inhibition of the noradrenaline release and inhibition of the acetylcholine also release, inhibition of the insulin release also. So alpha 2 is inhibitors. It is inhibition. Beta 2 we can use it in, I would say, tachycardia, and increase lipolysis, increase myocardial, I would say, contractility, and increase release of renin. So whenever there is a release of renin, you have to mention it is the beta 2. And beta 1 beta 2 is vasodilation and slightly decreases peripheral resistance, and there is a bronchodilation, increase muscle and liver glycogenolysis, increase release of the glycagon, and release uterine smooth muscle. These are the classifications which we have to, what are the functions of the adrenoreceptors. Now, biosynthesis, dopamine, norepinephrine, and epinephrine. The amino acid tyrosine, as you know, it is an important amino acid, is transported into the sympathetic nerve axon. Tyrosine, TYR, is converted to dopa by tyrosine hydroxylase. This is a rate limiting step for norepinephrine synthesis. Dopa is converted to dopamine by dopa decarboxylase. Dopamine is transported in the vesicles, then converted to norepinephrine by dopamine beta hydroxylase, DBH, and this is transported into the vesicles. Now, this is overall biosynthesis of dopamine, norepinephrine, epinephrine, catecholamines. So L-tyrosine, tyrosine hydroxylase is this, and then L-dopa, then dopa decarboxylase, then dopamine. Then dopamine is dopamine beta hydroxylase, and then is the norepinephrine. It is PNMT, phenylethylene, and methyltransferase is S-adenosyl methionine. It is converted to epinephrine. So this is the overall biosynthetic pathway. Now, adrenergic or catecholamine transmission, steps involved in cholinergic transmission, synthesis of the norepinephrine, storage of the norepinephrine into vesicle, release, then it is being released, binding by receptor, removal by norepinephrine, reuptake, and metabolism. So this is all about how it is adrenergic catecholamine transmission takes place. Now, adrenergic or catecholamine transmission, the amino acid tyrosine is transported into the sympathetic nerve axon. Tyrosine is converted to dopa by tyrosine hydroxylase, rate limiting step by for norepinephrine release. Dopa is converted to dopamine by dopa decarboxylase. Dopamine is transported in the vesicle, then converted to norepinephrine by dopamine beta hydroxylase, DBH. Transport into the vesicle. Then an action potential traveling down the axon depolarizes the membrane and causes calcium to enter the axon. So this is all about the adrenergic transmission. Now, increased intracellular calcium causes the vesicle to migrate to the axonal membrane and fuse with the membrane, which permits the norepinephrine to diffuse out of the vesicle into the extracellular junctional space. The norepinephrine binds to the post-junctional receptor and stimulates the effector organ response. This is all about how this transmission takes place. Now this is all, the synthesis takes place, and it goes inside, and then it is converted, and the uptake mechanism is there. Number 2, it is dopamine, and then dopamine from here it is a release of the norepinephrine, and this is release, and there is the presynaptic receptor like alpha 2, and then there's a fifth, there's the removal of the noradrenaline, and then the metabolism is being taken up. It is the metabolism. Norepinephrine methylated by this is metabolized by the comet and MAO. This is the overview, and then there is the intracellular response. Intracellular response is this, and then we have two enzymes: catechol O-methyltransferase and MAO. So this you have to, this is, I would say, divided into synthesis of norepinephrine, then uptake into storage, then there is the release of the neurotransmitter, then there is the binding of the receptor, then there is the, I would say, removal of the norepinephrine, then there is the metabolism. These sequences you have to remember, and you have already learned in the, I would say, first year. Now, metabolism of the catecholamine is very important. Norepinephrine or epinephrine is metabolized by catechol O-methyl transferase, COMT, and monoamine oxidase, MAO. The final product of these pathways is vinyl mandelic acid. So this you have to remember, this catechol O-methyl transferase inhibitors we have to, I would say, cover in the Parkinson's disease, and MAO inhibitors where we this I would say we have to make this adrenergic store, this metabolism we have to, I would say, inhibit in the tricyclic antidepressants, like we have in depression we use it. So vinyl mandelic acid is the marker where this VMA can be, I would say, can be used in, I would say, for chromocytoma. So this is because there is a turnover more, and you will come to know in the alpha blockade and the use of the hypertension, this cyclophosphamide and vinyl mandelic acid. You have to remember, we do the test in vinyl mandelic acid in hypertension when there's a hypertension is very, very high because of the adrenergic store, because of the pheochromocytoma. This is very important so far as clinical manifestation is concerned. Now, metabolism of norepinephrine is COMT, and dihydroxymandelic acid is also VMA, vinyl mandelic acid, and norepinephrine also, normetanephrine also is converted into vinyl mandelic acid. So COMT here we have norepinephrine, COMT here we have dihydroxymandelic acid. It is also COMT because MAO and aldehyde dehydrogenase norepinephrine goes to and produces the dihydroxymandelic acid. Then COMT is very important. Here is also COMT important, and MAO and aldehyde dehydrogenase converts the normetanephrine into the VMA. Now norepinephrine, COMT, it is, I would say, give normetanephrine. Then from norepinephrine, it is through MAO, there is a dihydroxymandelic acid, then COMT is there and becomes MAO. So same is the case with the epinephrine. Epinephrine is converted to MAO, dihydroxymandelic acid, and norepinephrine is come through MAO, it comes to dihydroxymandelic acid. But once the epinephrine to COMT, when there is a COMT, it is the metanephrine which is formed. So from metanephrine, this MAO comes and vinyl mandelic acid is formed. So this is the MAO is the monoamine oxidase, COMT is catechol O-methyl transferase. This is biosynthetic pathway. Just because you should know this biosynthetic pathway, it is used in therapeutics. Once you have COMT inhibitors and MAO inhibitors, you have to read. Now, regulation of the norepinephrine release. Norepinephrine acts as alpha-2 autoreceptors and inhibit adenyl cyclase. So alpha 1, it increases the adenyl cyclase, but alpha 2, it is autoreceptor, it inhibits the adenyl cyclase, thus decreases CMP concentration, suppression of the calcium channel, which inhibits exocytosis. So this is the case where the clonidine is the agonist that is used for antihypertensive, and it is alpha 2 agonist. It acts as autoreceptor and it inhibits the adenyl cyclase. Now, classification. Drugs can be classified according to pharmacological actions. Drugs can be classified according to chemical nature. Drugs can be classified according to mechanism of action. So we have 3 classifications. Now, according to pharmacological action, vasoconstrictor like adrenaline, norepinephrine. These are the vasoconstrictors. Noradrenaline, norepinephrine is the vasoconstrictor. Now, vasodilator, dopamine, isoprenaline, these are the vasodilators. And bronchodilator, salbutamol, terbutaline, and these are the bronchodilators. CNS stimulants, amphetamine, methylamphetamine, these are the, this is according to the pharmacological. So we have pharmacological action, type of mechanism of action. We have 4 classes of drugs: vasoconstrictors, vasodilators, bronchodilators, and CNS stimulants. Now, according to the chemical nature, catecholamine we call, because it's a catechol group. This is adrenaline, noradrenaline, and dopamine. So catecholamine we have 3: adrenaline, noradrenaline, and dopamine. Non-catecholamines we have amphetamine and tyramine. So according to chemical nature, we have 2 classes like catecholamine and non-catecholamine. Now, according to the mechanism of action, we have clonidine, dopamine, dobutamine, epinephrine, norepinephrine. They are direct acting. And indirect acting are amphetamine, tyramine. They are indirect acting. Mixed acting is ephedrine. So they have both connotations. Mixed acting, we have according to mechanism of action, direct acting, we have indirect acting, and we have mixed acting. So because direct acting is clonidine, they act on through the adrenergic store, and amphetamine acts through another pathway, tyramine, that's indirect acting. But mixed acting is ephedrine. So their classification depending on the mechanism of action. So we have now classification adrenergic drugs, direct acting and indirect acting. Direct acting, we have natural compounds, synthetic compounds. From natural compounds we have epinephrine, norepinephrine, dopamine, and we have synthetic compounds, alpha agonist, beta agonist. And so far as the indirect acting is concerned, we have releasers, they release, and uptake inhibitors and MAO inhibitors. So far as classification is concerned, you have to remember this, and all drugs are being classified according to this classification. Adrenergic drugs are being classified directly, natural, synthetic. And in indirect acting, we have releasers, uptake inhibitors, and MAO inhibitors. Now, direct acting, natural compounds. Directly acting are mostly natural compounds. So these include epinephrine, norepinephrine, and dopamine. If these catecholamines are released from nerve fibers, these are called the neurotransmitters. If released from the glands, these are called as the hormones. If released from the outside, these are called as the drugs. So this is what is classification of directly acting. Now, according to that, directly acting synthetic compounds, we have alpha agonists, phenylephrine. These are the synthetic compounds now. Phenylephrine, methoxyline stimulates alpha 1 receptors. Clonidine, dextromethorphan, xylazine stimulates alpha receptors. So this is the alpha agonist synthetic. Now beta agonists synthetic are isoproterenol stimulates beta 1 and beta 2 receptors. Dobutamine stimulates beta 1 receptors. Terbutaline, salbutamol, clenbuterol stimulates beta 2 and so we have alpha agonists, we have beta agonists, and beta agonists can be beta 1 and beta 2. And terbutaline, salbutamol, clenbuterol stimulates beta 2. And accordingly, you have to, these are the synthetic compounds, these are not the, natural compounds. Now, indirect acting, releasers, they are releasing the adrenaline. The tyramine, amphetamine, ephedrine, these are the releasers. Uptake inhibitors is cocaine, triphenylamine, they are uptake inhibitors. MAO inhibitors are isocarboxylate, phenelzine, iproclozide, procarbazine, hydralazine, and phenoxypropaxine. These are the MAO inhibitors. So these are very important in drug agents, and they are not nowadays, but you are supposed to touch it once we do the TCA, tricyclic antidepressants. And uptake inhibitors is cocaine and these were used. Now they are not, they have a lot of potential of adverse drug reactions. They are not used nowadays. These are called the indirect acting. And amphetamine, we use it, and ephedrine, these are the releasers. Now, mechanism of direct action. Direct acting against these drugs act directly on alpha or beta, producing effectors similar to those that occur following stimulation of sympathetic nerve or release of the hormone epinephrine from the adrenal medulla. So this is what we direct acting. Once they directly act on these adrenergic drugs, and these are the effector sites where they act. The indirect acting. These enhance release. They are not acting directly, but they enhance the release norepinephrine from the ending. These drugs block and reverse the activity of the norepinephrine transporter. NET, we call it norepinephrine transporter. NET is a transport protein present on surface of some cells that clears adrenaline and noradrenaline from the extracellular space into the cells, thus terminating the signaling effect by inhibiting the enzyme monoamine oxidase. So this is reuptake. So they are being indirectly acting. So this is reuptake. It is again stored in the norepinephrine, then again. So it maintains the store. So this is very important. This is the effector site. So mechanism of action of the mixed type. Mixed action agonists, they have capacity to both to stimulate adrenoreceptors directly and to release norepinephrine from the adrenergic neuron. So indirectly acting is like here, and mixed effect is also here and here both, and direct effect is effector site here. So indirectly is at the store level, and mixed effect is both at the synapses and the store, and direct is at the effector site, post synaptic. So this is mechanism of the mixed action. Now pharmacological action of adrenaline we have on eye, we have on cardiovascular system, heart and blood vessels, we have on respiratory system, we have on gastrointestinal tract, we have on urinary bladder, we have on kidney, we have on central nervous system and liver and pancreas. This is the pharmacological action of the adrenaline. Now pharmacological action on the eye. Adrenaline binds with alpha-1 receptors, cause contraction of the pupillae muscle, increase outflow of the aqueous humor, decrease intraocular pressure, and relief is produced in the and glaucoma. Now pharmacological action on CVS, heart, increase blood pressure. So on blood vessels, low dose adrenaline binds with beta 2 receptors on large artery and vessel of skeletal muscle. Increased CMP causes vasodilation and decreased blood pressure in low dose usually. Usual dose of adrenaline binds with alpha 2 receptor on at arteriole, precapillary sphincter, mucous membrane, and renal tissue that increase the DAG, diacylglycerol, IP3 and calcium, and influx and increases the PR and increase the blood pressure, peripheral resistance. So this is the pharmacological action on the heart, on the blood vessels. What are the different receptors, beta 2, and what are the through the DAG and IP3. This is very important. It increases the blood pressure. Now on pharmacological action on the lungs is the bronchodilator. GIT relaxes of the GI smooth muscle and contraction of the sphincter that we call as the constipation. And the urinary bladder, relaxation of the detrusor muscle of urinary bladder and contraction of the sphincter, that is the urine retention. So pharmacological action on lungs is bronchodilation, GIT is constipation, and urinary bladder is urine retention. Now pharmacological action on kidney, increase renal secretion, increases the angiotensin second, and renal vasoconstriction is produced, and salt and water retention is there, and increased blood pressure. So adrenergic store on pharmacological action on kidney is angiotensinogen second, because the renin is increased and there is a renal vasoconstriction and increase of the blood pressure is there. Now pharmacological on liver, increase the glycogenolysis and glyconeogenesis and increase blood glucose. And pancreas, alpha 2 receptors decrease insulin secretion. So alpha 2 has a decrease in insulin secretion. Beta 2 receptors increase insulin secretion. So they are alpha 2 is antagonist to beta 2 on the pancreas. Alpha 2 is in decreased insulin secretion, beta 2 is increased insulin secretion. And CNS mild restlessness, insomnia, tremor, and euphoria. So this is the mechanism on different organs. So indication. Now what is the indication of the symptomatic amines? In large purpose is an anaphylactic shock. Cardiovascular application. Cardiogenic shock is there, dopamine, dobutamine is given. Cardiac arrest is there, adrenaline is given. Heart block is there, isoprenaline is given. Heart failure is there, dobutamine is given. Respiratory application, we have severe acute bronchial asthma, we give the salbutamol. And as nasal decongestant, we give oxymetazoline. This is local, ephedrine, systemic. So this is we have indication number 1, anaphylactic shock, cardiovascular application, respiratory application. So anaphylactic shock is IgE mediated, that you have to, this adrenaline is the drug of choice. Now anaphylactic shock, we will describe it here. Anaphylaxis is a serious allergic reaction that is rapid in onset and may cause death. It typically causes a number of symptoms including an itchy rash, throat swelling, and low blood pressure. Common causes include insect bites, stings, foods, and medications. On a physiological level, anaphylaxis is caused by the release of the mediators from the certain types of the wider WBCs, triggers either by immunologic or non-immunologic mechanisms. So this is the pathophysiology of the anaphylactic shock. Now, anaphylactic shock clinical feature is bronchospasm, hypotension, blood pressure is decreased, and allergic reaction is there. And general management is should stop the drug immediately, and patients should be kept in supine position with elevated legs. Respiratory resuscitation is maintained, and monitoring the blood pressure is very important. This is the anaphylactic shock, how we, this clinical feature is there, and what is the general management. Now, anaphylactic shock, role of anaphylactic shock. In anaphylactic shock, there is the rupture of the basophil and mast cell membrane, and subsequently massive release of the histamine takes place. So there is a bronchoconstriction, there is a hypotension. Adrenaline causes elevation of the blood pressure by binding with alpha-1 receptors. So anaphylactic shock, adrenaline is given because it acts on the alpha-1 receptors. Prevents bronchoconstriction, and bronchoconstriction is prevented by binding beta-2 receptors. Then it binds the beta-2 receptors. Now, adverse effects due to the symptomatic amines is hypertension, tremor, insomnia, retention of the urine, constipation, may cause dyslipidemia and hyperglycemia. These are the adverse effects you have to remember. And then dopamine, separately will also it is a neurotransmitter. Receptor is D1, D2, and on site is brain, smooth muscles of the renal vascular bed, and effect is adrenaline cyclase is increased, CMP is increased. But D2 we have brain, smooth muscle, presynaptic neuroterminal, adrenaline cyclase is decreased, and voltage gated calcium current and potassium channel is decreased. So this is the effect between D1 and D2. Now, where it is indicated dopamine? We give in cardiogenic shock, we give in severe CCF, congestive cardiac failure, we give in malignant hypertension. So this is the indication for the dopamine. And then, thank you very much. This was all about the class, and I hope you would have, this is the, I would say, main points. You would have, I would say, you have to elaborate it nicely. Thank you very much.